Everyone, welcome. We're so happy to have you all. And thank you so much for joining us for the World AIDS Day webinar. Now, as people are coming in, we have attendees from all over the world, and we also have three expert speakers who have agreed to spend some time with us so that we can all learn a little bit more about why this is such an important topic. Before we get started, I want to tell you all a little bit about myself. My name is Hannah Jacobs. I am a pre-medical undergraduate student at Yale University, where I study the history of science and medicine. And I'm also the representative for the American Academy of HIV/AIDS Medicine. And I'm very, very honored to be with you all tonight. Now, before we get started, we are just going to have a brief warm-up to really just get everyone into the mindset of World AIDS Day and what we're really trying to accomplish. So we're just going to have a few moments. We will also be sending a link in the chat, but we want to know where in the world you guys are joining us from. So as you all start responding, I will be sharing your responses. Wow, okay, we have a lot of people from the US. We have some people from South Africa, from Australia, from Europe as well. This is very exciting. Someone all the way out here. And this is really helpful because we have a lot of very unique perspectives, and we're very excited and very grateful to have you all here with us. So as you all kind of take your time to settle in, please just take a moment. We're very curious. We want to know where you all are joining us from. And also, if you feel comfortable, please feel free to turn on your cameras and show your faces. So this can feel like a very open, very welcome dialogue. We'll give a few more seconds for that. I see we have some more responses. We have someone out here, which is really exciting. Wow, people from all over. Thank you all for joining us, especially with the time differences. Wow, wow, wow. Okay, we're wrapping up with that. We have another question for you all. And we're kind of curious, what comes to mind when you think of HIV care? So we will also be sending a second link for that. But please just take a moment to share with us what comes to your mind when you're thinking of care, and treatment, which will be very relevant to a lot of the conversations we'll be having tonight. Expensive, yes. It's a really good point. It's a very good, very important point. Harm reduction, yes, it's definitely at the center of HIV care and treatment. Medications, a very important part, PrEP and PEP. Threaten, that's a very interesting one. It's just very true. Very expensive, very expensive. What else comes to mind? I'm very curious. Medications is definitely a big part. Sex, immune, harm, stigma. Stigma is very important. And I think very central to the conversations that are most important when it comes to treatment. Provider, your future providers, current providers, and you play an important role. Preventative, new, antibiotics. These are all really good. Needles, yes, definitely, definitely. Stigma, definitely. Wow, these are so great. Thank you all so much. This is amazing. Disposable, thank you. System. Oh, yeah. Thank you so much for everyone who was able to participate in that. I think you all showed and provided some very good insight. Now, kind of transitioning back to what we have planned for you all tonight. Here we are. I want to give you all a brief overview of what we have on the agenda. So we will begin with some introductions from the American Pharmacists Association and the American Academy of HIV/AIDS Medicine. That will be followed by a brief overview of our goals and ground rules for tonight's session. Um, and then following that, we will have our speakers. After each speaker, we will have a brief 5-minute Q&A. But if you don't have the chance to get your question asked, we will also have a general Q&A at the very end, where you can pose questions to any or all three of our speakers. And at the end, we'll be closing where we will have a brief feedback survey that we all encourage you to fill out, especially if you're interested in getting a completion survey that we will be emailing out at the conclusion of the session. All right. So I will hand it over to my co-host, Ahmed Noor.
Thank you, Hannah. And hello, everyone. My name is Ahmed Noor, and I serve as the National Project Coordinator for APhA with the International Standing Committee. Thank you all again for joining us today, and I'm excited to hear from our speakers and have them share their knowledge on this topic with all of you. I wanted to give a brief introduction of APhA. Um, APhA is the first established professional society of pharmacists in the United States, founded in 1852, and it represents over 62,000 pharmacists, 62,000 members, including pharmacists, pharmaceutical scientists, student pharmacists, and pharmacy technicians. And in APhA, we strive to promote the value of pharmacists in healthcare and provide continuing education, professional development, opportunities, and resources for our members. APhA consists of 23 communities, including the community of student pharmacists, which is APhA-ASP, and that was established a little over 50 years ago, and now represents over 45,000 members across the United States and Puerto Rico. And finally, as APhA-ASP student pharmacists, our mission is to serve as the collective voice for student pharmacists, to provide opportunities for professional growth, to improve patient care, and to envision and advance the future of pharmacy. And now turn it back to Hannah for the AHIVM introduction.
Thank you so much. The American Academy of HIV/AIDS Medicine is the nation's leading independent organization of healthcare professionals dedicated to providing excellence in HIV care and prevention. The Academy works to promote patient-centered sexual health care by building and supporting a diverse healthcare workforce, done by leveraging provider expertise to make a more equitable healthcare system, and by advocating for patients, and respect for provider care. The Academy supports HIV practitioners and promotes accessible, high-quality care for those with HIV and communities overrepresented in the HIV epidemic in the United States. Our members and credentialed HIV specialists, HIV pharmacists, and HIV experts provide direct care to a majority of HIV patients in the United States. The four pillars that are at the center of our mission and goals as an organization are to educate, credential, connect, and to advocate for improvements in HIV treatment and prevention. We are very excited about the future of HIV prevention and care, and we offer a free student membership to anyone enrolled in a health professional program, including MDs, DOs, RNs, PAs, and PharmDs. Okay, moving forward, I'm going to hand it back over to Ahmed.
So now when you're thinking why we're here today, um, I'm sure you all have your reasons, but just to give you some background, HIV continues to affect millions worldwide, and that is a reality that demands sustained global attention. And by the end of 2024, over 40 million people were living with HIV globally. That is a huge number, and yet too many still suffer consequences and insufficient care. And in 2024 alone, around 630,000 people died from AIDS-related illnesses. Deaths that are for many could have been prevented with timely treatment and support. Importantly, among those living with HIV, millions remain without reliable access to life-saving medication. Um, but the treatment has transformed HIV into a manageable chronic condition for countless individuals across access to antiretroviral therapy, also known as ART, combined with consistent care and adherence enables people with HIV to maintain their health. When viral load is suppressed, not only is the individual's health preserved, but the risk of transmission drops dramatically. And that is a fact that underscores the importance of treatment, monitoring, and adherence support. And these outcomes demonstrate how critical strong healthcare systems and trained providers, including pharmacists, are for long-term um, care success. And so the road ahead still remains uneven. Globally, by 2024, only 73% of people living with HIV were receiving ART, which is about 20% short of targets set by the global health agencies like the WHO. And although virus suppression is possible and effective, many individuals lack reliable access to testing, treatment, monitoring, or support. Of course, a lot of that is because of structural barriers from geography and cost to stigma and supply disruptions, which all persist universally. And so that is why this moment matters. On World AIDS Day, we come together to renew our commitment. We advocate for equitable access to testing, treatment, and care services for everyone and everywhere. And as global health and pharmacy professionals, we have both the knowledge and the responsibility to ensure that HIV care becomes the norm and not the exception. And moving on to the next slide. And so the goals for this webinar, by the end of this session, we hope that everyone here learns something new. We have excellent speakers from diverse practice areas who will highlight the role of pharmacists in HIV care and access. And we'll try to make this as interactive as possible through the Q&A sessions that you heard about earlier. And moving to the next slide. And just to give you all an introduction to our speakers, so on the left here, we have Dr. Kelsey Aragon. Dr. Aragon is an associate professor at the University of New Mexico College of Pharmacy, where she also serves as the director of student pharmacist career planning and co-director of the ambulatory care residency program. Her clinical practice is based at Truman Health Services, a Ryan White funded clinic where she provides comprehensive care for patients with HIV and their diabetes, cardiovascular risk, and those with or without HIV with gender dysphoria as a pharmacist clinician. And next we have Dr. Cassandra Esperant. Dr. Esperant is a senior medical scientist for Gilead Sciences in Florida, where she focuses on HIV treatment and prevention through scientific exchange with healthcare professionals. She earned her PharmD from Nova Southeastern University in 2011 and transitioned to HIV specialty care in 2018 with AIDS Healthcare Foundation. There, she opened and managed a clinic-based pharmacy at the AHF and led innovative programs, including pharmacist-led PrEP prescribing under a collaborative practice agreement, the implementation of long-acting injectables, and the piloting of an at-home PrEP kit program. Her work helps establish a pharmacist-led PrEP services as a recognized model of care, and Dr. Esperant has also served on the board of directors for the American Academy of HIV Medicine and remains active in professional coalitions supporting Haitian American healthcare initiatives. And then finally, we have Dr. Kenrick Ware. Dr. Ware is a clinical associate professor of pharmacy practice at Mercer University College of Pharmacy. He serves as a district director for the South Metro West region of the Georgia Society of Health System Pharmacists. Dr. Ware participates as a member, excuse me, of the Clinician Advisory Board, 6 Protected Class, also known as 6PC, Partnership for PharmD Access. And furthermore, Dr. Ware contributes to and coordinates volunteer pharmacy services at the Georgia Harm Reduction Coalition, in conjunction with Mercer University College of Pharmacy. And Dr. Ware currently also serves as the chairperson of the American Academy of HIV Medicine, Georgia chapter. All right, and moving on to the next slide. So finally, for our housekeeping, just for quick housekeeping before we begin, our goal is to keep this session under 90 minutes. Each speaker will present around 20 minutes, followed by a 5-minute Q&A session. At the beginning of each speaker session, I'll send a link in the chat for you all to add your questions. There will also be another QR code at the end to enter your questions. We will also be monitoring the chat, but we will take questions from the Google form first. And towards the end of the session, we will send a feedback form. It is important that you submit and add your email and names to the Google form, as that is how we will track attendance and send your certificates. So please make sure you enter your name, how you'd like it to appear in your certificates, and enter the email address that you'd like us to send the certificate to. And with that, Dr. Aragon, the floor is yours.
Thank you so much. Give me one second. Um, would you mind if I share the slides from my computer? I have them
Sure.
downloaded.
Yes.
Thank you so much. Share. All right. How does that look?
That looks
Great.
great.
My name is Kelsey Aragon, she, hers. I am a pharmacist clinician. And so in New Mexico, we have something called a pharmacist clinician, which is very similar to a nurse practitioner or a PA. So we have independent practice where we have independent prescriptive authority. I do have a supervising physician that kind of approves my overall protocol, but our protocol is very wide open. And so in my protocol, it kind of goes through what disease states I can manage, but it doesn't tell me what medications I can or cannot use or anything like that. And so it's really a wonderful place to be able to practice. And I think it's helpful to start at that point so that way we all kind of are on the same page, because what I do is very different, I think, from what I have done in community-based practice or other different settings. And so today we're going to be talking about, I just wanted to share like different pathways on how to find a role in HIV care. And I think that can be in a variety of ways. It doesn't have to be a formal title where like that's the only patient population you're caring for, right? Because HIV competent and HIV preventative care is everyone's job on the healthcare team, regardless of what setting that you're in. We're going to talk a little bit about some of the unique pieces about HIV care in the setting of having amazing treatments that we talked about, right? We have medications that keep our patients alive longer and they live healthier lives. And with that, there is a great role for pharmacists and pharmacy to help make sure that we're managing these comorbidities or other disease states that might pop up in the long longevity of someone's life when they're living with HIV. And so a lot of those pieces that we're finding out now are things that are related more to our metabolic function and our metabolic conditions. And then we're going to talk a little bit about maybe how you find your role on an interdisciplinary team. What are some of the ways that that relationship could work? Today, specifically, I just wanted to talk about our ability to impact cardiovascular care and health in people with HIV. And to me, this means a lot of different things, and we'll go through some of those pieces. But I think because we're all student pharmacists here, for the most part, it seems like it's helpful to understand like how do you get to where you are or where you might want to be. There is no right way to find a career path, I think, and a lot of it is trial and error and being open to opportunities and to doors as they come, because you never know what is going to kind of change and spark joy in your life. And so the best advice I ever got when I was thinking about what I wanted to do after graduation was to go where the people I want to serve are. And so I had, so in America, in our education, we, at my school that we did, there's different formats. So there's some schools of pharmacy that are 0 to 6 programs where you go straight out of high school and you start pharmacy school. And then 6 years later, you graduate with your doctorate of pharmacy. There's programs where you do 1 to 2 years of undergrad, then you can apply to pharmacy school, and then you do a 4 year program. There's now 3 year programs. There's now 3.5 year programs. My experience was I did 2 years of undergrad, and then I am from New Mexico, from a very small town called Belen, where there's one pharmacy. I remember when they opened up the first Walgreens, I was like 12. I remember when the Walmart came into town. And so like I came from a very small experience, and I love being a New Mexican. I love my community, and I never thought about trying to go anywhere else really. And so I applied to the University of New Mexico College of Pharmacy. Pharmacy felt like a good fit. I wanted to do healthcare. I feel like when you're growing up and you're interested in chemistry, it feels like sometimes mentors in your life are like, you should do pharmacy. And I don't know that I do a ton of chemistry right now in my job, but I do love what I do. I love getting to talk to people and to my patients. And so, because of that, my program was 3 years in the classroom and then 1 year of your rotations. And we did 4 week rotations. And I got assigned to the clinic that I'm in, to Truman Health Services right now. I was a student pharmacist. It was my first ever experience working directly with people with HIV and people that were gender expansive. or transgender. And so this was my first ever real exposure to these patient populations that I knew of, right? Because we interact with people with HIV, we interact with people who are gender expansive all of the time, whether we're aware of it or not. And so this was my first opportunity to serve these patient populations. And it changed my life. Like, I loved this clinic. I loved this patient population. I loved the idea that I could serve such a deserving patient population that had been through so much historical trauma and medical trauma and current trauma and stigma, and that I could show up and be my best self and give them the highest level of care I possibly could. That for me was like a calling. And I knew I wanted to do that. I also got mentored by a lot of people in my life that means that you should do residency if you want to go into a clinical practice space, right? And so the more time I spent in a hospital, the more time I felt very confident that that was not the place that I wanted to spend my time or serve. I just don't enjoy being in the hospital setting. I really enjoy talking to patients. Um, and so I did love the community-based setting. I worked at Walgreens my entire time in pharmacy school. I really loved it. I love the chaos of not knowing what someone's going to ask you when they walk up to a pharmacy counter, or when they ask you for a recommendation. And so I really loved using my brain in that way, because I truly feel like community-based practice is practicing at the top of your license. Now I have the luxury of looking at someone's labs or ordering someone's labs. When I worked in the community-based setting, you don't have that luxury, but you still have to help your patient. And so I think it requires you to use every piece of knowledge that you've ever been taught, in a very unique and impactful way. And so I felt like I didn't want to do hospital based because I felt like I really loved the community base, but I had to make the decision to leave New Mexico because there was not any community based residencies in New Mexico at that time. And I wanted to teach. I wanted to get a teaching certificate in a residency program. I wanted to learn how to think outside of the box and to build business plans. And so a community based residency was really the right fit for me. And if I hadn't been involved in APhA ASP as a student, I would have had no idea that community based residencies would have existed, and my entire career path would have looked vastly different. And so staying involved in IPSF and APhA ASP, wherever you are, is so important because it's the networking that you make when you're involved in AAHIVP, AAHIVM, all of those pieces, like a free membership. I hope all of you sign up for that membership, because the networking that you will make, and just from the emails that you're going to get in your inbox that are going to open your brains to new ideas and new possibilities that you might not have known existed before, those are the things that open those doors that I was talking about and cause you to think in a different way. And so it's so important to stay involved. That's my number one advice. But I had to decide what to do after residency because I really didn't want to be in the hospital. That meant I had to leave New Mexico. And I had to explain to my family why I was going to try to go to a Walgreens HIV Center of Excellence in Asheville, North Carolina, instead of accepting my Walgreens offer to be a full pharmacist here in New Mexico. So I was going to get paid a lot less to move across the country to work for the same organization, but it was important to me, and I had to tell them why. And the why was because that was where the people I wanted to serve are. I wanted to learn how to provide HIV preventative and HIV competent care in the community setting. I was on a syringe exchange committee for the county there. I did outreach at senior centers and with the unhoused community. And I just totally knew that this is where I wanted to be. And this is the space and the patient population I wanted to serve. I still wanted to go back to New Mexico because this pharmacist clinician thing is really, really good area of practice for what I wanted to do in the ambulatory care space. And so I was able to come back and do my PGY2, or a second year of postgraduate training with the University of New Mexico College of Pharmacy. And I got to spend 3 months at Truman Health Services, where I practice now, during my PGY2, because my preceptor, who was in my clinic, my exact job actually prior to me, her husband was in the military, and they got orders to move and relocate February of my PGY2 year. And so there was really going to be this opportunity for someone to step into her clinic. And it was already what I wanted to do. And so I worked with the different providers there. We kind of changed and made my residency really fit to make me be a good candidate for that role. I was able to get that role out of residency. And the other piece of advice I always give is there's nothing scarier than getting what you feel is your dream job as your first job, because it's a lot of high stakes to not try to mess it up. And so luckily I still love what I do. And I really do love everything about what I do. And we'll talk about what place I practice. After I graduated residency, there's always certifications that you can do. And so the first thing I did was I got diabetes. I became a diabetes certified educator, because that one you don't have to do. I did that during my PGY2 residency, because I did a lot of diabetes management and I still do. And then I am board certified in ambulatory care and AAHIVP. And the HIV pharmacist exam is extremely doable. You just have to show up, and show up in your clinical practice space prior. So you have to do the work, but if you're serving that patient population and if you're getting your HIV CEs, you can sit for that exam in a very reasonable amount of time. And it's a very reasonable exam. There's a lot of resources available. And so that's my newest, but also one of my most impactful certifications. But the place that I practice and that I serve and work is UNM Truman Health Services, where actually right now at this exact same time, they're also celebrating World AIDS Day. So every single year, we get together as a community, not just at our organization, but we invite our entire community in Albuquerque, all of our patients, all of the community groups, the Transgender Resource Center, to this really beautiful World AIDS Day celebration where everyone lights candles for loved ones that they've maybe lost to the HIV epidemic. It's just a space to come together as community. It's very empowering and inspiring. And so I'm sure every single one of you has access to either a virtual platform that is similar like this, like congratulations for being here and welcome, because it's important. But if you're like, I am invigorated after this and you want to figure out where to go next, there's probably a local organization near you that does a lot of really great things. And seeing how you could get involved as a student pharmacist with those organizations can be very, I think, empowering. What Truman Health Services look like is we're called a medical home, is what we call ourselves. And so we have our patient, and our patient is surrounded with all sorts of wonderful people. The darker orange are people that are quote unquote prescribers or seen as prescribers at our clinic. And so I am the clinical pharmacist, so I'm the pharmacist clinician. They have appointments with me just like you would have an appointment with your doctor. And so they don't see a doctor when they see me, they come to my visit and they're seeing me. And I really do a lot of the management for things like diabetes and hypertension and hyperlipidemia. And I do a lot of, I think pharmacists have a very unique way of looking at things that sometimes other providers don't necessarily look at things the exact same way that we do. And so it's really wonderful to work on an interdisciplinary team and to be able to impact healthcare in that way and our patient populations. And so we are very fortunate to have a lot of people on our healthcare team, and our patients are at the center of every single thing that we do. And so Ryan White funded clinics are really great opportunities. So Ryan White was actually a teenage boy who was diagnosed with HIV in the early 90s, late 80s. But he actually got HIV from a blood transfusion, because when we don't know something exists, we don't know that we should be screening for it. And so he was one of the individuals that got HIV through a blood transfusion. And then his school, when they found out at that time, there wasn't a lot of treatment options for HIV, right? And there was a lot of stigma, because when we don't understand something, we tend to be afraid of it, it seems like, as a culture and society. And so his school didn't want him to come back to school. And his mom and him fought for that. And they actually are the reason that all of these Ryan White funded clinics, so it's a grant, a federal grant that exists that helps support people that are doing HIV care. And so it's impacted and changed lives for millions of people. And so we are an HIV funded clinic. That's where we get a lot of our funding to do the things that we do, to have access to acupuncture and chiropractor at our clinic, and community outreach and all of those pieces. And so those are things like if you're a student pharmacist and you're interested, finding Ryan White funded clinics to either volunteer at or get a job as a community health worker during school, or if they have a pharmacy, maybe you could work there as a pharmacy intern or a pharmacy tech before becoming a pharmacist to see if you like that culture and that fit. Those are great opportunities. The really cool thing about people with HIV and the treatment that we have is when they have access to treatment, they are going to live long and healthy lives. And pharmacists can play a huge role in this. We know that people with HIV are at a higher risk of comorbid health conditions. So they're at a higher risk than someone without HIV for developing things like hyperlipidemia or lipid disorders, diabetes, hypertension, obesity, kidney disease, ASCVD, anxiety or depression, or osteoporosis. These are all places and disease states that pharmacists can have a direct role in their care. And so we not only get to help patients get access to HIV medications like antiretroviral therapy, but we get to help them live healthy, high quality lives. And that is such a cool place to be. And so I am not the pharmacist when someone has super resistant HIV and I need to go back and do all of their resistant panel stuff. That is not me. That is my really good friend and colleague, Bernadette Jakeman, who I had a patient today and I said, this person's CD4 percentage is 10%. Their viral load was a little bit high, but always because they have very resistant HIV. Their CD4 count was still over 200. So it was like, I think we might be in stage 3. Their primary care provider said they were stage 1. Having a colleague that does the work and that I could go up to her and say, hey, can you look at this chart with me? And then I could say, like, actually, I'm going to schedule them with you because we had already ordered all of their genotype testing, all of the things. And so when you work with a team, or if you don't have access to someone at your clinic where you can walk up to, when you join professional organizations like AAHIVP or AAHIVM, you have a whole network of people that you could ask. And I think that that is another reason why it's super important, because it allows you to do the work that you are trained to do and that you love to do, knowing that you're going to be able to find someone who can help fill any of the questions that you have that might come up for a patient. But when we think about all of the pieces on this last slide, a lot of them have to do with how healthy our heart will end up being. So if you have CKD, you're very much more likely to end up with cardiovascular disease. ASCVD is a version of cardiovascular disease in a lot of ways. Obesity is another inflammatory. I always like to tell students, almost all of these are diseases of inflammation. And so it is our job to protect people's hearts and to prevent any sort of heart conditions and to reduce the risk of heart disease when possible. That can come in a lot of ways. So specific numbers is the risk of diabetes diagnosis is 4 times higher in people with HIV. Prediabetes is also increased. When someone gets diagnosed with prediabetes, we assume their pancreas is doing the best that it possibly can, and there's probably about 60 to 70% left of real beta cell function or pancreas function. Once they get diabetes, that's about half. And so when we have a disease state like HIV that might increase these risks, we need to be more cognizant and monitor a little bit more. As a pharmacist, you know these things, and you can make sure that we're getting the labs, we're doing the screenings, we're following up. We're thinking differently, and we're thinking about some risk factors. Like, what are some of the antiretroviral therapies are they on? Which ones have they been on in the past? Because we know that some of the medicines that have kept people alive for a really long time also had consequences, but the benefits much outweighed the risk. So when we think about the history of HIV treatments, right? We started with medicines like zidovudine and stavudine that were basically toxic to people. They made people feel really bad. They caused a lot of deficiencies. They caused a lot of side effects. And so why did we just use them at the end of life? It's because we didn't have treatment options like we do today. We didn't expect people to feel better. We just wanted to keep them alive as long as we possibly could. And so when we started treating HIV, we waited until people were really sick. And then we started giving them one medication at a time because we knew they would be develop resistance. We knew we didn't have better treatment options. We were just trying to prolong their life. And the quality of life was sometimes so devastatingly low that patients stopped taking their antiretroviral therapy. That is not the case today. But there is historical trauma related to HIV care. And so when we think about patients that are on things like medicines like Triumeq, which has abacavir, and we know now that abacavir increases someone's risk of having a heart attack when they're on it and when they've recently been on it. But when I have patients that are on Triumeq and I try to say, hey, there's better options, can we switch you to something like Biktarvy? And they're going to say, why would I ever get off of a medication that has kept me alive when I have seen people that I love succumb to this disease or be really sick and they didn't have Triumeq, but I do. So why would I get off of it? It is like that is a historical medical trauma that we are now having to make sure that we're being providing competent care. And so those conversations look different versus me telling someone we can get you off metformin today and we can get you on a GLP-1. That conversation is usually a lot easier for me to do than talking about I recognize that this medication absolutely saved your life. We are so grateful that it existed. And today we have other options that are even better. And so pharmacists play that role in being able to help support our patients. All of the diabetes and the hyperlipidemia pieces are also sometimes side effects of some of our oldest medicines. But you know what? They got that patient there today. They kept them alive. And now we, as pharmacists, and as the medical team, can do all of the best care that we possibly can with the amazing medications we have now. And we're going to treat those conditions because they're treatable, right? But what's not treatable is when we didn't get to where we are today. And so recognizing that pharmacists play a huge role in this and that all of your knowledge is applicable, right? You are going to make a huge impact in this patient population, and it's so important. So my role in clinic is I do prescribing and managing a variety of conditions. And so I can order labs, I can prescribe medications, I do diabetes management, blood pressure management, weight management, which that is like one of my big things that I really love to do because I love talking about weight in a way that is patient focused because there's a like I'm not going to tell someone they need to lose weight. We talk about like what their weight journey is and where they want their weight journey to be. And so every single piece of care that we do needs to be patient centered because the best medication that a patient can get is the one that they're willing to take. And so if we're not having those conversations about the medications the way that pharmacists are trained to do, we're going to potentially do more harm than we do good because it's easy for them to tell me they're taking their meds. But if they weren't part of the original decision to taking that med, there's a chance that they might not actually want to. Metabolic associated steatohepatitis, so fatty liver disease. But we don't call it that anymore. We do that. We do smoking cessation management, hyperlipidemia, asthma, and I do hormone therapy for people who are gender expansive. In people who are trans, so trans females are around 4 to 5 times more likely to contract HIV in their life, and trans men are actually 2 times more likely than a cis male or cis woman population to contract HIV. So both of those patient populations are more likely to get HIV in their life. And so it's a great place to do not just access to hormone therapy, but also access to things like PrEP. And those are the big pieces. Hannah, do you have a question about this slide or at the end? I might have gone over my time.
At the very end.
Yes, yes, you have. Thank you.
Yeah. What questions do you have, if any? And I could wait till the end.
Thank you so much, Dr. Aragon. We have
Yes.
one question in particular that I think is very, very relevant. And this person asked, what cardiovascular risk factors unique to people with HIV do you feel pharmacists are best positioned to manage?
So many of them. I mean, I think the hyperlipidemia from like some of the older HIV medications is a great place, but blood pressure things, because I think we understand that the first blood pressure you get at clinic is not the most accurate one. And so we should be rechecking. And all of those pieces. Pharmacists are just extenders for primary care. And so oftentimes, like we might be able to get seen for that 4 week follow up for a blood pressure medication start where they might not be able to see their PCP for a while. And so we're able to be a primary care extender, which is really cool.
Thank you so much. It is my pleasure to now invite Dr. Esperant to the stage. Dr. Esperant, would you prefer to present the slides on your own, or would you rather I?
I think I'm going to share the slides. Thank you so much, Hannah. Good evening, everyone. Again, my name is Cassandra Espira or Cassandra Esperant. You can see it either way. And I am a pharmacist. But before I continue, I just want to say that the opinions expressed are my own and do not represent those of my employer. So let me just go ahead and prepare to share the slide. I think you guys may need to share it for me because it's not letting me share it because I think I'm just an editor. Thank you. Okay, so just in the chat, how many people are interested in working and having something to do with HIV when you graduate? Just a show of hands. Okay, so I'm not able to see the chat. Is anybody putting anything in the chat?
I saw there like the hands up in the emoji in the
Okay, Public University. And, and at that time, and retail, I decided that I wanted to enter specialty, right? So what did I do? I position, and guess what, guys? I was not prepared. So I just want to stress the importance of continuous education, right? Always be willing to develop yourself, right? Always continue to do, because remember, once you graduate, only 60% of that knowledge is relevant for the most part, right? So it's definitely always have a way of continuing to educate yourself. So a few years later, I got another opportunity after learning that, and I got an opportunity to work for the AIDS Healthcare Foundation. So with that being said, next slide, please. With that being said, I was able to like develop my skills as a clinical pharmacist, which was one of the coolest opportunities because the pharmacy that I opened, we actually took care of all the STIs for the whole county and Broward, which is a county in Fort Lauderdale. And with that, I had the opportunity of not only helping to manage HIV patients, but these patients who were getting diagnosed with sexually transmitted infections, we were able to start them on HIV prevention, right? So that is probably the coolest opportunity. So imagine having a pharmacy where you would enroll maybe over 15 new patients on HIV prevention a day. So shortly after that, there was an opportunity for pharmacists in Florida to have collaborative practice agreements. So I decided to, speak to my leadership and initiate the conversation. Is this something that we can do? Is this something that you can work on? And I had the opportunity to kind of trailblaze that and just create the best practices and the protocol. And I just like want to encourage you guys to always try to advocate for our profession because we definitely need one voice, because, we're trying to get like, hashtag pharmacist provider status, right? That's definitely something that's super important. And I think the biggest challenges that are presented with that is that every state has their own legislature. I can't speak right now. All the different rules. So I think that as an organizations like American Academy of HIV Medicine, APhA, thank you so much for this collaboration. This is what's going to help get pharmacists collaborative practice, underway. So some of the lessons that I've learned working in HIV is the importance of serving diverse and underserved patients. Even speaking to the barriers when it comes to HIV prevention, right? There's a lot of disparities in that. And before I end this presentation, we'll talk about some of the HIV incidents and what the populations look like. It's definitely important to develop cultural competencies, right? To know how to talk to different patients, to the different providers that you see, and also seeing the impact of pharmacists beyond dispensing. I remember when I was leaving the pharmacy and focusing more on collaborative practice, it was the strangest feeling for me. Like I wasn't going to be dispensing medication anymore. It was like, part of my identity. It was really a challenge. So, I challenge each and every one of you to try to find some sort of advocacy that you believe in. And I think that's the only way that we're going to not only end the HIV epidemic, but also to push this profession forward. And this also this all came about because of the passion I have for, equity, advocacy. I had so many amazing opportunities to lead with advocacy. So in Florida, we recently got a bill for post-exposure prophylaxis, and I had the opportunity with the AIDS Healthcare Foundation, which is an organization that's also focused on advocacy, to actually go to Tallahassee and present public statements to help that bill get passed. And I've done some advocacy with AAHIVM in terms of doxypep. So there's just so many opportunities as a pharmacist. Next slide, please. Awesome. So again, I'm going to stress the importance of continuing to develop yourself in terms of education. A great opportunity is with the AAHIVM. All student memberships are free. Please take advantage of that. Seriously, guys, this is so important because I will tell you that a majority of the opportunities are based on your networking. That is probably one of the most important skills that I learned too late. And it is so important because this is where, you get opportunities for mentorship and things of that sort. So I myself have challenged my fear of public speaking. This happened around COVID 2020. What I did was I actually hired a coach, and her name is Christina Madison. She's also known as the public health pharmacist. And she was able to help me challenge my fear of public speaking. And I was able to get so many opportunities, right? After I started getting coaching sessions with her, I was able to become a speaker for the AIDS Education Training Center, where, I would, based at a university in Miami, where I would provide education on HIV prevention. It's probably one of the best decisions that I make. Again, I'm going to stress the importance of always continuously developing yourself, and there's a lot of non-traditional pathways to doing that, and this was like my specific pathway. So not only was I developing programs with my employer, AIDS healthcare provider, I was out in the community having conversations, being on panels. So there's so many different ways. And once I gained the confidence of presenting clinical data, I also got an opportunity to be on the speaker bureau for Gilead Sciences, where I was a speaker for HIV prevention. So, all this really led to the role that I have now. So I also obtained a collaborative practice agreement where I helped implement pharmacist-led prep at the AIDS Healthcare Foundation. And that was probably one of the best opportunities that I had because pharmacists, we really do need to focus on collaborative practice agreement because that's a huge opportunity. And I think within the profession, we are divided on how we feel about that, right? So it's definitely a great opportunity for us to expand our career and to get, more opportunities as well. And also always focus on your personal brand. So during my uh, transition, as I was developing myself, facing my fear of public speaking, I also started an Instagram, and it's called the Prep and HIV Pharmacist as well, where I, discuss, different topics about HIV prevention and just like it just created an opportunity to, create my brand. Next slide, please. So as of this year, I have transitioned to be a medical scientist, and I am now with Gilead um, for HIV treatment and prevention. And in my role, what I do is I have scientific exchange with key opinion leaders and clinical providers as well. And, it's just an opportunity to influence on a broader scale. I definitely, in my role now, if I meet pharmacists, I encourage them to join the academy, get credentialed. And I want to pass on that baton to you all so that you guys can continue my initial efforts when it comes to pharmacist-led prep. Super important. We definitely have a huge opportunity to end the HIV epidemic by doing this as well. Next slide. So I also wanted to share that I know that APhA as well as AAHIVM, and they're partnering to promote this program, this content, which is a pharmacist-based HIV prevention services curriculum to help pharmacists, be able to have the confidence and have the education in order to be ready to provide like pharmacy-based PrEP prevention services. So I had the opportunity to, help with the content and help develop this training program as well. Next slide. So I just want to end on this note. So in terms of HIV incidence, African Americans account for about 12% of the population, but about 38% of all HIV cases. When it comes to the Hispanic and Latino community, they account for about 19% of the population, but yet account for about 34% of all new HIV cases. And when it comes to the white community, it accounts for about 58.2 of the population, but only 22.7% of the cases, right? So this is just, I just want to, this today's World's AIDS Day, right? So I just wanted to leave the conversation on that note that there's so much work to be done. And I think that as a profession, pharmacists will have a huge impact the more organized and more like that we can have some national guidelines to kind of align so that we can have collaborative practice agreements. I feel like this is how I always thought of it. Like, how there was a time where Plan B was prescription or behind the counter, like, and you can go and just get a Plan B from a pharmacist. I feel like post-exposure prophylaxis would be a perfect opportunity. There's always a pharmacist at the pharmacy during the weekend. And I think that this would make a huge impact in ending the HIV epidemic. And that's all I have for you guys today. And I'm ready for my questions.
Thank you so, so much, Dr. Esperant, for sharing that. Um, One question that we have here, um, what current or emerging therapies do you find most promising in HIV treatment or prevention?
You said what therapies?
Current or emerging therapies.
Okay, so because I work for pharma, I'm not going to discuss the therapies too much, but I'm going to just generally say that, we have single tablet regimens. So we've come such a long way. There was a time where we would have like a cocktail of medications, and now patients can have single tablet regimen. And also we have long acting regimens in the pipeline, which is amazing. We have medications in the pipeline right now on the market. There's a every 2 month injection for treatment. And very soon we'll have, more frequent, less frequent and less frequency in terms of like when it comes to HIV treatment. Was that helpful? Or reach out to me offline and we can talk more.
Thank you so much. Another question we have is, do you see a large overlap in HIV and sexual health and reproductive healthcare opportunities for pharmacists?
Absolutely. I think there's a lot of opportunity, but I think that we need to create the structure first so that we can have these opportunities. If we don't have the structure and the organized, can you guys see me? Hold on. if we don't have the structure and and also come into an agreement and how this is going to be done, but there is a lot of opportunity. Like for example, for myself, my personal advocacy is making sure that people in heterosexual communities, women know that this is also something that they need to think about, right? If you look at the incidences of HIV, there's a rising number of HIV cases in heterosexual communities. And just having this conversation and having pharmacists who are knowledgeable about this, because we're the ones who see our patients every month, we dispense their medications. We can, have these conversations when we're, for example, let's say a patient comes and requests an over-the-counter medication. That's a perfect opportunity to have that conversation. Or when we're dispensing the birth control, I think there's a huge opportunity. Absolutely.
Definitely. And one last question we'll take for right now. Remember that if you have a question for Dr. Esperant or Dr. Aragon, we will revisit and have an opportunity for questions later on in the presentation. But what we're going to finish with for right now, well, someone says, from your experience transitioning from direct patient care into a medical science role, what skills or habits do you think student pharmacists should start developing now if they want to eventually influence HIV care on a broader population level scale?
Building relationships, right? And I think that one thing is always enter your relationships adding value to everybody you come into contact with. That's like kind of my personal mission because it's so important to earn the trust of people that you're interacting with, right? Because again, you are building a brand. So when you go into these interviews, all the relationships that you've built, all the people that you've interacted with. Remember that, guys. There's everybody is connected. So it's so important to be very intentional in how you connect with people and leave people feeling. And also always be willing to learn and develop your clinical knowledge, right? Because it's something that you can learn now. Get involved in research as well. It's very important to have that skill because it's about building the relationships, having empathy, because I think it's very important to do that. And then joining organizations and getting into the leadership because believe it or not, people will start recognizing who you are. So it's important.
Thank you so much. It is my pleasure to introduce our final speaker, Dr. Kevin Ware. Dr. Kenrick,
Good
would
evening.
good
Uh,
evening. Would you prefer for me to continue presenting or would you like to do it on your own?
yes, if you would continue, that would be great. Thank you. It may just be on. Oh, all right. Sorry, it was delay. Okay, I see it now. All right. Good evening, everybody. Again, my name is Kenrick Ware, and as was stated, I'm on faculty at Mercer University College of Pharmacy. I'm really excited to be here with you. I'll kind of give a little bit of my background verbally as my journey to my role here. Actually, in healthcare started before pharmacy. I worked as uh, a medical laboratory scientist or clinical laboratory scientist in the lab. So I had a kind of a different route to pharmacy school. So I worked in microbiology. I did some blood banking work. And so I was a clinical laboratory scientist that really set the stage for me going to pharmacy school. So I learned a lot about, again, microbiology, chemistry, so all the labs that we typically order or we see prescribed. I was able to run those firsthand in my role prior to pharmacy school. I also got some training in phlebotomy. So I was a phlebotomist for a period of time. So kind of a really interesting route to pharmacy school. And I attended pharmacy school at Howard University College of Pharmacy in Washington, D.C. Then after that, I completed a postgraduate year one and year two residency in Savannah, Georgia. Then I transitioned to Columbia, South Carolina shortly thereafter. And a lot of my involvement that I'll speak to today really speaks quite a bit to my role in South Carolina prior to coming to Georgia not too long ago. So I want to kind of talk contextually from a statewide perspective, kind of talk a little bit about some involvement I've had at the state level, particularly again more through a South Carolina lens, as I've only been really practicing in Georgia as a pharmacist most recently for the last couple of years. I also want to talk about something I'm really excited about as far as evidence to practice or a campus-based initiative where a group of us, a team of us, go to different college campuses to raise awareness not only about HIV prevention, but careers that people can explore, undergraduate students should be thinking about as they move into the next phases of their life. And lastly, I want to kind of talk a little bit internationally. I had a wonderful opportunity to serve as a Fulbright scholar and spend some time in Cameroon for about a month several years ago. And I was paired, excuse me, with a HIV researcher there at St. Monica University. So I want to kind of speak a little bit about that involvement and what that did for my professional growth. So next slide. Thank you. So again, I kind of dubbed this as career explorations, opportunity for impact. So I really like the previous statement about creating value and what you can do to really try to add value to wherever you are, whatever situation you're in. I think that's extremely impactful. I'm so glad that was stated because that really could it cuts across any area that you're interested in, right? If you're adding value, right, I think people recognize it, that people respect it, and they want more of it, right? In essence, that would be where more spaces that you'll be welcomed into. So I definitely want to underscore, foot stomp, highlight, whatever you prefer on that comment because it's extremely important. All right, next slide. So I want to start here with one of the things I had a privilege of doing in South Carolina was working on the HIV Planning Council. And one of the roles, so as you can see, I was previously at South University School of Pharmacy prior to arriving at Mercer. And South had, at one point in time, a dual campus model where it was a school in Columbia, South Carolina, where I primarily spent my time, and a school in Savannah, Georgia. And through my work in the community there in Columbia, I worked with the HIV Planning Council and we developed an HIV and aging survey. And this survey was geared toward people living with HIV 50 and above, looking at residents in South Carolina, looking at their needs changed over time. But one gap we noticed was that the survey was only in English. So when we came up with the survey, we only had the survey developed in English. And I really believe I was a benefit of good fortune because had three students on rotation with me who were APhA students. One was from Cameroon, one was from Puerto Rico, and one was from Vietnam. And I said, well, we ought to try to translate this survey into your respective languages. And so the goal there was for them to learn more about HIV care provisions. The survey was fairly lengthy, but they were able to really kind of unpack the information because, as you can imagine, for them to translate it, they needed to really understand what the survey said. So they understood the survey, I would imagine, at more of a surface level initially. And then as they got into some of the translational aspects, some of the really good questions came out about how do I say this and what should I say to that? And so this opportunity emerged. And so we published this in the International Journal of International Students, where this article really just described the role of these pharmacy students in their translational capacity. So it's a really cool experience. So outside of the publication product, we were able to create, I guess you call it more of a repository of surveys in French and Vietnamese and Spanish. And so it's just a really cool experience. The students we're really excited about it. We were in partnership with the University of South Carolina as far as developing the survey, but actually having the survey translated was a cool opportunity for students to really learn more about the world of HIV and to also contribute. And as to, again, the comment I want to continue to echo, to really add value to our council, right? Because again, we didn't have the survey available outside of English. Next slide. So this was some of the content that was as far as the survey. So as you see, it was a kind of quite a few things we asked. It was fairly comprehensive. other people taking the survey would have a different word for it. It was too long, it was burdensome, but we recognized that it was a bit lengthy. And so in hindsight, that was something that we could have gone back and maybe abridged it some. But these are some of the just some highlights of the questions we were asking about, people who were living with HIV in South Carolina, 50 and above. How was transportation for them, nutrition assistance, other considerations, particularly have you ever had at least a 1 year gap in seeing an HIV care provider? So that was important because obviously we were concerned about people uh, being lost to follow-up or falling out of care. So we were really concerned there. The most recent viral load and being diagnosed with AIDS. And so some of the findings from our study that you can see, we had a very, I would say fairly low sample size if you look at the amount of people living with HIV in South Carolina, and you contrast that to 50 or 64 people, right? We didn't, our sample size really didn't measure up in that respect. But one of the things we saw when we did some analysis, we didn't do robust statistical analysis, but when we looked at it, we saw people who were without full-time employment were 15 times more likely to not have had a medical appointment before 1 month after testing HIV than those with full-time employment. So obviously we think about some of these social determinants of health and other things, right? That's a big consideration there. We saw some statistical significance there. And people who identified as Black had about 10 times higher odds of being diagnosed with AIDS than people who identified as white. So that was something else that we noted. Now, admittedly, this was a smaller sample size. The race distribution was fairly equal in our sample, if you're wondering about that. But again, the sample size was very small. But this was an opportunity to do some stats, to kind of review the statistical processes with students at the time. So I kind of used it as a teaching tool as well. Our next slide. Another opportunity I had in South Carolina was I served on something called the Fetal Infant Mortality Review Committee. And this committee actually, and it sounds like, kind of looked at different types of considerations around mothers who were living with HIV and if they went on to deliver a baby living with HIV. The way we talked about, obviously, it's World AIDS Day and advancements that we made. If the mother's viral load is undetectable, really we at the place in time where the mother really shouldn't deliver a baby with HIV, right? We have too many options and too many therapies for that to happen. Well, unfortunately, in this case, it did happen, and the rationale was the mother was on an antiretroviral regimen of atazanavir and ritonavir with tenofovir and nitrosidabine. So as pharmacy students, you're probably learning about some of these drugs or have learned about them, but atazanavir is one of our protease inhibitors boosted by ritonavir, right? Another protease inhibitor. So when we say boosted, it really kind of increases the levels of it in the body. And tenofovir and nitrosidabine, we really refer to as like a backbone therapy. Some of our nucleotide reverse transcriptase inhibitors, our NRTIs. So the mother was taking this regimen. One key point is atazanavir really needs that acidic environment to help with absorption. And so the mother was taking all of the medications at the same time. However, the healthcare providers, as a part of this case, and so I must say this, I was a part of the retrospective arm of it. So this had taken place. And so I was brought in to kind of try to assess from a pharmacy perspective, what could have gone wrong. And as you can see, this is what went wrong. This was my first time on the on the committee, and I noticed this drug interaction with the patient taking famotidine, as we know, H2 receptor antagonist that could obviously is indicated to decrease acidity for different types of conditions. And so ultimately what happened was this drug was decreasing the amount of the atazanavir in the body. And so if you look up the drug interaction, right, it's pretty clear, right, that what could occur. And so the unfortunate part about this case was that the mother attested to taking the medications as prescribed, doing everything that we asked her to do in the healthcare system with all of our white coats and the things behind our names. And ultimately, as a healthcare system, we failed her because we blamed her for not taking the medications as was prescribed to her. And ultimately, unfortunately, her baby went on to live with HIV. And so this was something that, again, I was brought in on after the fact, but it speaks to the importance of having pharmacists in the mix early on, early and often, right? So this was, and even more tragic was it was a team full of healthcare providers who overlooked the drug interaction. And when it was brought to me, basically, they asked me if I had anything else to say, but they were getting ready to move on to the next case. And I was so shocked by what I saw that I actually looked the drug interaction up myself again, just to double check it. And it was still true. So the thought here is, again, we need pharmacists to be a part of the healthcare team at every step of the process. But ultimately, we need to have more respect and treat our patients with more dignity and do the best we can to prove them right as opposed to proving them wrong. Next slide. So this evidence to practice is a collaboration among a group of us, right? So really it's an effort led there at Duke University Center for AIDS Research. And so this is a tremendous opportunity where we basically canvass the country at this point, going to undergraduate institutions, really raising awareness about PrEP. And really the thought is how does undergrad students really view PrEP in their local context, right? And we've also gone to a few pharmacy schools as well. So our goal is to really kind of try to help empower them to be PrEP champions, public health ambassadors, really there at the level of either their undergraduate institution or in the pharmacy field. Next slide. So this is our team. So the idea was initiated and birthed with Dr. KK there at Duke University, who's an associate professor of medicine. It was interesting how we all met. So Dr. KK met Mr. Campbell, and then I ended up meeting Dr. KK when I was in South Carolina. And we all just formed this group where we were able to and are able to go to different institutions. So here we're featured at Morris College in Sumter, South Carolina. And so we go to these places for 3 days. I have a slide that I'll talk more about that. But we spend about 3 days on campus, really understanding PrEP through the lens of college students and what would it take to implement PrEP in their local context. So next slide. So this is our structure. So you see over the course of 3 days, the first day is admittedly probably the longer day, is heavy on didactic as far as the local HIV epidemiology there in the institution where we are, in the environment where we are. They learn about domains of like implementation science, human-centered design, and then we do an introduction to HIV prevention modalities. So that whatever's available on the market at that point, we discuss. And then day 2 and day 3 is really where the students work in groups to really come up with different action plans to really fit their local context around, again, not just raising awareness for PrEP, but what can they do in their communities to basically mobilize some of their efforts out into the communities. Importantly enough, we compensate the students for their time. So in essence, they would get $300 for completion of the 3-day session. And so that's something that we pride ourselves on because we view them as context experts, right? So while we may be or bring content expertise, they have the expertise on their lived experience in their local context. All right, so next slide. All right, so these are just some themes that we see when we're going through at the different campuses. So as you can see, these are some of the things that come up. One of the things of note is the rap battles with PrEP content. So this was an interesting idea. But one college campus decided that they wanted to actually have a rap contest about the different formulations of PrEP that were available on the market. To raise some awareness around it, the rap battle was really designed to argue why one formulation was better than the other formulation. And so it would be something that would be showcased to people there at their institution. All right, next slide. And it's really the output, right? So we think about the campus action plan. So as you can see, they're color coded by the colors of the different universities. So we started off primarily focusing on South Carolina. I was there at the time, and also if you're familiar with the federal priorities throughout the United States, obviously South Carolina is one of those areas that gets a lot of attention in that respect. So 3 of these institutions are in South Carolina, and we also did some work in North Carolina as well. All right, next slide. So lastly, again, the opportunity to participate in the Fulbright scholarship. And again, going back to that adding value component, I was actually invited to participate in this at the recommendation of someone at Benedict College. So I didn't work at the institution, but I worked in the community with the dean at Benedict College, and he actually wrote me into the grant. So that the value piece, again, I can't underscore that enough. I mean, that's so important because again, this was an opportunity that I didn't even know about, and in essence, I didn't even apply for. But I guess I applied through showing up and doing what I had committed to do. And then the dean at the time at Benedict said, "Hey, would you like to join us in Cameroon?" I said, "Of course I would." So next slide. Just kind of talked about some products that we were able to generate from our time there with some of the researchers. The thought here, we looked at the awareness and willingness of HIV PrEP to use HIV PrEP among community residents. Interestingly enough, in this survey, one of the key findings we saw was that people who identified as being married were more in favor of using PrEP than those who were unmarried. One of our suspicions was there in Cameroon, like other countries, the male partners can have multiple wives. And so when you look at perhaps this was an opportunity for some of the women to really try to guard against HIV by empowering themselves with PrEP in light of the fact that their spouse may have multiple other wives. We also obviously during that time was really more, I guess, HIV adjacent, but we looked at COVID perceptions too, right? Because that was kind of the time where we were trying to figure out what were some of the barriers around vaccine hesitancy and other considerations there as well. All right, next slide. And so lastly, we were able to contribute to a book chapter. So that was something that everyone on the trip, so the Fulbright team, and you see the editors here, were at University of South Carolina and Benedict College, respectively. But we all got together and wrote a book about our experience. And as you can see, I dubbed our book chapter the Medicine Cabinet of the African Diaspora Literacy. So we kind of talked about some of the differences with how medicine is practiced in Cameroon versus in the United States. And Dr. Angelina Marcellus and I have been really close collaborators and good friends throughout that time. This experience actually happened 8 years ago now. It's hard to believe it's been that long, but we've been able to keep in contact and work on a lot of different things, even from afar. So thank you all for that, and any questions or comments, I would love to entertain them. So thank you.
Thank you so much, Dr. Kendrick Ware. We have lots of questions. First, someone asked, what kinds of ways can we expand HIV awareness, treatment, and prevention abroad?
It's a great question. I think, one way is, particularly if you get an opportunity to get involved with international organizations, volunteerism is a big key, right? So if you have an opportunity to do a mission trip or to study abroad, I think that's huge. You can always carve out some type of role with HIV care. When I spent some time in Cameroon, not only did we focus on HIV, but as a pharmacist, I was helping with just in there at the time, and perhaps still in present day, you can basically go into a pharmacy and purchase just about any medication you wanted to purchase. So it was good to have a pharmacist there to really kind of unpack what people were purchasing and some of the dangers of what they may be purchasing. So I think whatever you can do to connect with any international group that already has an infrastructure in place, going abroad and then carving out perhaps an HIV agenda, so to speak, or some type of itinerary around HIV within that framework. So you're not necessarily reinventing the wheel, but you can, again, add that value to whatever they already have in place.
Thank you. Someone else asks, in cases like excuse my pronunciation, famotidine and atazanavir interaction, where a system-level oversight led to preventable vertical transmission, what specific structural safeguards or pharmacist-led checkpoints do you believe should be mandated to prevent future failures, and how would you operationalize them in under-resourced Ryan clinics?
So great question. So I've obviously thought a lot about this since that occurred, and I think, well, ultimately, ensuring that when you have these interdisciplinary teams, that's the one that that I mentioned being a part of, is having a pharmacist on there is absolutely critical, whether it's in person or virtually. So I think that's one key component, right? I was actually the first pharmacist on the committee, and it had been in existence for quite some time. So I think structurally, whether you're looking at working with an academic institution where in some academic institutions, the pharmacist, like myself, the faculty member is completely compensated by the university. So if there is a cost containment concern about having a pharmacist on the team, maybe being creative and partnering with an academic institution or some other institution where the salary is offset to that particular institution, so you still have that pharmacy presence. I think that's a structural partnership that could happen because oftentimes people may cite the fact that perhaps the pharmacist salary is maybe not as budget friendly to their organization or what have you, but I think it's ways to work around that and still leverage the pharmacy expertise to ensure that you have pharmacy presence in some capacity.
And kind of continuing on that well-known drug interaction, someone asks, um, how do you think current PrEP and HIV care delivery models should be redesigned to decouple clinical outcomes from socioeconomic status apart from just expanding access?
So great question. I want to be clear. So that what makes this drug interaction even more egregious is that we had a ton of other options that the patient could have been on and continue to take the famotidine and everything would have been just fine. So I think when we're looking at through that lens, it was preventable in so many ways. But I think as far as we think about access, as what the presenter mentioned earlier, one of the presenters about the injectable options and things that are coming down the road or that are available now, I think it's important to make sure that when these products come to the market, that patients are comfortable taking them, right? So we talk about access from the standpoint of ensuring people get access to the treatment, but we also want to make sure that the community is ready for those treatments. And so we saw some of that even with the COVID vaccine rollout, and a lot of patients were hesitant about receiving anything related to a vaccine or an injection. So I think that's important as we start rolling out more longer acting injectables, is that we unpack some of the mistrust and distrust that people have of the healthcare system that would influence their willingness to actually have something injected into their bodies, right? I think, and if you look at the history of the healthcare system in this country, and I won't belabor it, the distrust and mistrust is justified in a lot of ways, right? And so I think we need to be able to be comfortable with that and really help people to have a voice in why they do or do not gravitate to certain options before we can basically bring what we feel to be the best option to them. It may be just a barrier, a mental barrier for them uh, gravitating to the newest option.
Thank you so much, Dr. Ware. Now we will open the floor up for questions to any of our three speakers. So as you continue to send questions in, if it is directed at one of our speakers, please just include the name in your question. Or if you'd like all three of them to give their input, please include that as well. Dr. Ware, we have another question for you. Someone asks, what do you think is the best way to integrate PrEP in practice? Should it start with physicians, PCPs, or in hospitals?
So just to make sure I understood it correct, what do I think is the best way to implement PrEP into clinical practice? Is that
Where should it start?
well, I think as we've seen with our panel, I mean, it doesn't necessarily have to be a certain type of provider, right? I mean, I think it should start as to quote another speaker, right? It's where the need is and where the people you want to serve, right? And so I think ultimately we really have an opportunity for PrEP to be. I didn't mention this, but I spent quite a bit of time working with a teleprep platform where we can actually do telehealth to deliver PrEP throughout the state, right? And so I think those are things that, I think it starts wherever the need is, wherever the interest is. And so we don't necessarily, it's a wonderful thing that we don't necessarily have to start in a certain place, right? We start again where that need is, where people are interested in it, and ultimately understanding the needs of that community. So when we think about, again, the telehealth space or the teleprep space is wonderful for a lot of people. For some people, it doesn't work as well, right? But we definitely saw a lot of barriers come down when we were able to meet with people virtually, get the medication sent out to them. They were responsible for doing their routine testing kind of independently. So I think we're at a place where we can start just about anywhere where the need is, right? And I think that's a really good thing.
Thank you so much. We have time for perhaps two or three more questions. We have a question for Dr. Esperant. Someone asks, what is the number one piece of advice you have for pharmacists interested in advocacy but are hesitant about if they have what it takes to get involved?
So definitely face your fears. And one thing that everybody can do as an advocate that includes healthcare providers, students, I think is learning the 5 Ps of sexual health. Has anybody heard of that before? The 5 Ps? I think that that's where it starts because in terms of the HIV prevention guidelines, there's this idea that it doesn't have to be the infectious disease doc having this conversation. It can be primary care. It can be the pharmacist at the local pharmacy. So it's just a matter of the 5 P stands for this: partners, practice, protection from STI, past history of STI, and pregnancy intentions. So I think it's super important that as healthcare providers, we have the comfortable aspect of talking about sex, right? We got to get comfortable with it. This is something that we don't learn in our training. And I think as students, each and every one of you can actually own that even before graduating, or if you come across a rotation, you can even have a conversation like that with your preceptor. I think that is a place that you can start as with your advocacy. And shout out to Dr. Riley for reminding me of the importance of this topic. And I believe that the American Academy of HIV Medicine even has a specific training for the sexual health questions and things like that. So I think that if we can normalize this conversation and make this part of the norm, and each of you can be an advocate for that, right? That can be a start. And you can, start doing other things. I think you have to follow your passion, right? Because when you're passionate about something, it comes easy. So although I don't like public speaking, but when I'm talking about something that I'm interested in, the passion comes out and I make it happen and people can see through that. So again, I think that's where you can start.
Definitely, definitely. Thank you so much. For our
Bravo.
last question, before kind of turning the floor back over to the three of you, for Dr. Aragon, someone asks, what role can pharmacists in New Mexico and other states that don't have CPAs in serving the underserved? Do you think that pharmacists have a provider role in serving those provider deserts?
Yeah, I mean, collaboration doesn't have to start and stop just because of like what your official role is. Pharmacists have been a key accessible healthcare provider in every state, regardless of what your practice looks like. And so, yes, absolutely. What that looks like is probably different types of relationships and intentionality with collaborating with local providers to ensure that like they're gonna, send over prescriptions or you're gonna be able to plug patients in, but all of that community building just improves patient care and access to care. And so, absolutely.
Thank you so much. I will be turning the floor back over to my co-host, Ahmed.
Thank you all for the wonderful presentations. And we're at the end of the session. And with that, I'd just like to leave you with this quote from the WHO Constitution. And for my last request, I would also like to ask our speakers if you could share something that certain pharmacists can do after today to contribute to this campaign's goals of raising awareness and advocating for progress in HIV prevention, treatment, and care. Whoever would like to go first.
I think being curious and keep showing up for the community that you want to serve.
I would echo that and just say, taking on projects, asking to be involved and not just taking them on, doing them at a high level and following up, right? I think, that's one of the key considerations is that is when you're looking to get involved is you learn by doing, right? So if it's a project, it's something that needs to be worked on. Most people aren't short on things that they need to do. They just don't have the capacity. So step in, raise your hand, take on that challenge to bring a project to pass and let that speak for you.
I agree with everything that was just said, and I think that it's following your passion is probably the most important because when you do something you're passionate about, it doesn't feel like work. I think that's so important. Um, I think that just knowing like what you want to do because I think you can start trying to do too many things. You kind of have to know your why. I think that's where it starts. Just knowing your why and knowing why you want to work in that advocacy. And first, like it doesn't like I think some people believe that, exploring, it's okay to explore and pivot. I think that's important too. So just knowing something that I realize is when you're in your passion, it comes easy and it doesn't feel like work. I think that's probably the most important thing.
Thank you all for your incredibly valuable insights, and thank you to everyone who attended from all over the world. We really appreciate you making the time with all of the differences in time and all of the very, I'm sure, very busy schedules. So yes, thank you so much for being a part of today's webinar. Please take a moment to fill out the feedback form. By no means do you have to complete the entire thing, but we encourage you to do so, especially if you are interested in receiving a certificate of attendance. But thank you all. Thank you to our speakers, and thank you to everyone in attendance. I hope you have a lovely rest of your day.